This is Frontline host Ryan Stanton. Before we get into today's episode, I wanted to invite all of our listeners to join me in Chicago this October for the 2026 ACEP Scientific Assembly. Alone, we each take care of our patients, but together, we can change the face of emergency medicine. Join me and thousands of your colleagues for ACEP 26. Register now at acep.org/ACEP26 and get free access to ACEP anytime. We'll see you in Chicago. Ryan Stanton here with ACEP Frontline. We got a little bit of echo because I'm out here in the hallway. We are at Massachusetts ACEP 2026, their annual meeting. And there was this very interesting topic that came up, and I wanted to get the interview, and thankfully she got here a little bit early and knocking it out. So talking with Dr. Alice Bukhman, and talking about the caring for the patients in custody. In this case, it's Massachusetts, but I think this is something that resonates around the country with how do we take care of folks in custody in the emergency department. So first and foremost, give us a little background on yourself. And, you know, as we're here, you're going to hear some doors coming, opening and closing. We're actually here at the Holy Cross. And it's getting close to graduation week and people are coming in getting their stuff. So the full NPR feel we've got going on. So tell us a little bit about yourself.
Yeah, so I'm an emergency medicine doc. I trained at Boston Medical Center and have been working at Mass General Brigham for the past about 10 years, where I'm the medical director for the Brigham Women's Faulkner Emergency Department. And I got involved in this work kind of, honestly, a little bit by accident. I had a friend who was the executive director of Prisoner Legal Services of Massachusetts, which is an organization that serves anyone incarcerated in Massachusetts. And she was looking for a physician because about 40% of the advocacy they do is actually around medical care.
Yeah.
And this was during COVID, when there was a great concern, a very legitimate concern about people getting COVID in the carceral setting, and how to manage that and advocate for people who were at particular risk. So I sort of helped with the job description, helped her think about it, and after a few rounds, she wasn't finding anybody, and I said, gee, this actually sounds really interesting. I don't have a ton of background in this, but I would love to interview. So I ended up being the person that they chose for the job, so I've been doing that since 2021, and really trying to help build their medical advocacy for people who are incarcerated in the state. And one of the main things that we've done is to try and recruit other physicians from Massachusetts and other medical providers to help in that advocacy. So we started a state chapter of a national organization called Medical Justice Alliance. It also was born out of COVID and the sort of crisis of people being locked up in the setting of a very dangerous disease. It was started actually by two emergency physicians. One was based in Chicago, one in New York, and happened to have one of those physicians here for a brief period of time. He was at Beth Israel, and we sort of joined forces to create their first state chapter of Massachusetts. So now we have about 50 members. We have created a clinic where we will look at cases that either Prisoner Legal Services or our public defenders or sometimes legislators will send us of people where they have concerns about whether people who are incarcerated are getting the standard of care, and to sort of review medical records and come up with sort of a declaration. Also a lot of work around medical parole, which is Massachusetts' version of compassionate release for people with terminal illness or permanent incapacitation, both in trying to strengthen applications for that for individuals, but then also look at the policy. And so yeah, there's been a lot of work. I think of my work as sort of being in three buckets. There's a lot of individual advocacy, and then there's advocacy within our institutions. So looking at the MGB system as a whole, both emergency departments, but also, the entire hospitals, Boston Medical Center, or other regional hospitals, and seeing how we can help strengthen our policies and the ability of providers to care for patients when they come into our community and academic medical centers, where people often I think, feel fairly without tools to know what to do. And then the third bucket is some of this policy work at the state and city level. What I'm here to talk about today to this audience is that tricky, I think it's always a bit fraught of when you have someone who comes into your care setting who is in custody, be it someone who was just arrested off the street, someone in ICE custody, or someone who is in a state prison who is being brought in, and you are trying to, follow your Hippocratic oath, deliver the best care possible, and there's a lot of roadblocks that you may encounter and really not understand why they are there, what you can do in negotiating how to give good care within the constraints that those you find there, and really try to find a way for advocacy that in the end is collaborative. I think I tend not to be a very confrontational person. I think it's always best to assume good intentions of everybody. And I don't think people involved in the guards or the police, I don't see them as enemies in this. I see them as collaborators. And that honestly, a lot of everybody in this is often confused and without a real clear roadmap of how do we do this together and make sure we're providing what these people deserve and need in terms of care.
All right, so let's talk about some of those gains, because, for me, living in where I do in Lexington, Kentucky, we have a federal medical center. They're just about to open up a state medical center. So what are some of the things that we need to consider? Because I think one of the biggest questions our physicians have is when somebody who's under arrest, incarcerated, comes in, what are the rights that they still have? Self-determination, those types of things. They don't have the freedom to walk around in society per se, but they still maintain some of their rights for self-determination health care, and I think all the states have some level of guarantee access to care for those that are incarcerated. So they have the guarantee to access to care. Now, whether that always happens or not, it's a big question, but talk about some of the rights that they have and that still the consent process that you would have with these patients.
Yeah, so it's really interesting, and a lot of this is state by state. So I can speak most intelligently about Massachusetts, but the Constitution applies to all states. So there is a constitutional, as you said, it's actually the only class of people in the United States that are guaranteed, or at least have been interpreted to be guaranteed health care, are people who are incarcerated in our country. And that's under the 8th Amendment, which precludes any cruel and unusual punishment. And this was a Supreme Court case that construed that to mean you have to give health care to people who are incarcerated. The bar for that is very low. It's adequate care. And there is no definition of that. And if you are going to argue that a facility is not providing that care, it's not just that they are not providing, that they have to show that they have had deliberate indifference to serious medical needs. So that deliberate indifference is very important. There's an intent implied there. So it's a very hard bar. I think many states, including Massachusetts, have really become sympathetic to the idea that people deserve the community standard of care, what they would get in the community, which I think is something that we are more familiar with from, malpractice and those sorts of things of what that would look like. And interestingly, in this, I don't think this is enshrined in the Constitution, but it is enshrined if you look at Massachusetts Department of Corrections own policies. They say, when the patient leaves our facility, they go to UMass Medical Center or Tufts Medical Center, the rules and rights of the patient of that institution apply to this patient. Mm-hmm. So they basically have all the same rights as any other of your patients, except, and this is the huge but, that security concerns will always outweigh the fulfillment of those rights. Mm-hmm. And so I think one of our tricks is to figure out when is there actually a real tension there. There are very few, but very, very high profile and high consequence cases of people breaking out of sort of having jailbreaks when they're outside of that very secure environment in a medical center. Obviously, no medical center wants that. The population doesn't want to have that, and no prison system wants to have that happen. So those anecdotes, I find often if you go through a policy, you could say, that seems very specific. And they'll say, oh yeah, back in 1972, this dude, did this or that. So, but when it comes down to the patient's rights, they have, and this I believe is, I'm not a lawyer, but would apply across the country. They have a right to informed consent. You can't do something against somebody without their consent. That means they can sign out AMA. That means they can say no to a procedure. So to sum up, the rights of the patient when they come into our outside institutions are essentially the same as any of your other patients, with the caveat that if there are security concerns, those rights may be outweighed. So most facilities will have a patient bill of rights, or the state may have a patient bill of rights. Those usually include things like confidentiality. So this is a great example. Someone comes in police custody, you want to ask them, what happened, And they may not want to give you a full history if they just use cocaine or, whatever happened. So you have a legitimate reason for both to protect the patient, but also to do your job, to want to get a confidential history. And what, at least in Massachusetts and in our, most of our, both our hospital institutions, and if you look at the sort of custodial authorities, what they have said is that those the guardian authorities need to be within line of sight of the patient, but they can be asked to move out of earshot, so that you can. Now, I don't know about your physical plan of your emergency department. That can be hard to do, or in an ICU or various places that could be tricky. But that is always something that you can ask for. They can always say no. They can say no. There are security concerns, and I can't do that. So it is a right that again is mutable based on what they say are the security concerns. Another example, when I was a brand new attending, I was working at a small community hospital out near the airport here in Massachusetts, and somebody was brought in by Customs and Border Patrol, and they were concerned about body packing. Mm-hmm. And they said, we want you to get a KUB on this patient. And I looked to the charge nurse and I said, well, this is weird. Like, is this? She said, oh yeah, it happens all the time. We do it all the time. And that was a sort of situation where I wanted to be able to get a confidential history from this young, scared man who didn't speak English to know, was this actually something he consented to or not? But this was be a clear violation of the patient's Fourth Amendment right against illegal search and seizure for me to force him to get an abdominal X-ray. And something that's important to know about that is that and this will sometimes happen in districts where police will come in, ask for blood tests, to get a blood alcohol level, those sorts of things. When you do it as a medical physician or as a medical test, that kind of gets around the Fourth Amendment. They can always subpoena that information. In order to, say, force that test to happen on somebody, they would need to have a search warrant. So it's a little bit of a backdoor in order to get that information. So that's another example of, Fourth Amendment right still there. Fifth Amendment right, your patient doesn't need to speak to anybody that they don't want to speak to. I think one that we get into a lot is informed consent. That is really tricky, especially when patients are critically ill and can't speak for themselves. A lot of our incarcerated population do not have a healthcare agent or healthcare proxy. And depending on the state that you are in, you may or may not have a default surrogate decision maker. So Massachusetts is a state where there is no default surrogate decision maker. So if someone does not have a designated healthcare agent and they lose capacity, technically you would need to seek guardianship, which we know is not something that you're going to be able to do when you're, I've just intubated somebody in the emergency department. But even, I will see, I review a lot of records for patients, and I will see people's healthcare proxies listed as medical director of the prison, which is pretty clearly never allowed. So that's an area where I think those patients have a clear right, and we have a clear obligation to try and get informed consent, but it's often not fulfilled.
It's interesting that you say that, because I had with to catch a smuggler, that whole idea. Cause I've probably seen that patient on the other side of the actual show, but the idea of a I was at a facility, they brought in 4 women and said, we'd like for you to do a pelvic exam because we think they have snuck drugs into the prison. And I was like, well, I have to have their consent. That's not only an invasive procedure, but they still have rights. And they're like, well, no, they're prisoners. Like, no, they still have rights over there. They still control their body. They just don't control their freedom. And so, I think that's something that's very important for physicians to understand your state laws and kind of be aware of what's going on there. But, you mentioned that case where they came in with that. And I think most physicians would just say, oh, yeah, sure, go ahead and order the x-ray and do it. What are the potential risks of doing something just because the officers or whoever asked for it versus the potential risks like we saw in the pit where somebody gets arrested, where you actually stand up and say these patients have rights.
Right, and I think that the recent immigration enforcement has all made us maybe a little bit more worried about what happens if you do stand up to authority. So I don't want to sugarcoat it and say it's not without risk, because both ways, yeah. So, people who are in prison, tend to have a lot of time and they tend to be a pretty litigious group. So technically, if you were to say do a pelvic exam on somebody against their will, that would be assault and battery. And they would have a pretty good case against you for that. So, that would be a risk, for sure. I think there's also a lot of moral injury risk, and that's probably the main risk to you, is that you feel pretty crappy at the end of the day that you did not sort of fulfill what you became a physician to do by doing that. I think the risk of saying no, what I recommend people do, especially because this is thorny, and what I have discovered is the law, often medicine seems super complicated and there's so many gray areas. Law is even more gray. So what I recommend is if you're ever in that kind of a confrontation, don't go it alone. Mm-hmm. You almost always have some kind of legal backup that you can call. And I would bet money that almost any hospital lawyer, if you called them and said, hey, there's somebody here that's asking me to do a pelvic exam against somebody's will, that they would back you up and say, yeah, no, that's against a patient's rights and we will protect you. But I think it's always good to take that moment, politely say, hey, do you mind? I'm just going to call the lawyer on call and discuss this. I'm not trying to be obstructionist. We also tell people to do that when, there's been a lot of concern about people coming in with warrants, looking for people that come into your emergency department, say, with a removal warrant. And, there are many different types of warrants. Some warrants allow people to come in and grab somebody. Some warrants do not. And what I recommend is that you not try and interpret that yourself, that you call your legal department and say, hey, this is what I got.
Well, I got to get you to your talk. You're coming up soon.
Well, thank you for warming me up.
Yeah. Talking with Dr. Alice Bukhman from Brigham and Women's Hospital, caring for the patients in the custody in Massachusetts, and thank you for the time. And for the listeners out there, sorry for the noise. We're in a student center, and what I've learned from the Church of the Holy Cross is that there's a lot of flip-flops, there's a lot of loud doors, and occasionally people don't see people with microphones and understand that they're doing an interview.
And what I would say, just as a plug to your listeners, is if this is work that interests them, that the Medical Justice Alliance is an amazing organization. We have many, many ways to get involved and to support people even in your local institutions, to look at your policies, to speak with your security and your legal teams to try and figure these things out before they come into your emergency department, which is, we always want to be prepared.
Well, I appreciate it. Thank you. I invite you to check that out. As for me, you can contact me at rstanton@acep.org, rstanton@acep.org, or at EverydayMed on X. And, appreciate everybody tuning in. Make sure you subscribe on your favorite player and give us a 5-star rating. Help boost us up and spread the word to your friends, families, others in medicine or may be interested. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
Far away to a quiet If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
There. Quiet place, all
Yeah.
alone. Da-da-da.